Thank you very much for giving me the opportunity to present our data. I have nothing to disclose. So the background why we performed this study is that there's a high incidence of groin hernia, as we already heard today, with up to 20 to 25 persons per 10,000 inhabitants. The Tapp repair or laparoscopic repair is increasing in European countries. Around 30 to 40% is performed laparoscopically. And the Tapp repair is the most used laparoscopic repair. There are just little data on health-related quality of life in the literature, and there are no long-term data up to 10 years. And far more, there are little data on sports hernia, although this is a problem in professional sports athletes, up to 30% in soccer players and ice hockey players and football players. And there are no data on health-related quality of life in the long term after sports hernia repair. So what is the sports hernia? First, it's a diagnosis of exclusion, and second is a clinical diagnosis of chronic painful musculotendinous injury to the medial inguinal floor in the absence of a groin hernia. So if you look on this very complex anatomic region, you find many reasons which can make a chronic groin pain. And just looking on the orthopedic regions, you see there are many possibilities which lead to chronic groin pain in the athletes. If you look in the inner side, the typical Tapp view, you see that the sports hernia problem is mainly in the conjoint tendon right next to the Hasselbalch's triangle. But if you look on the outer side, you will see that the pain is located on different regions, mainly because of the variation of the local nerves. And the main pain syndrome is in this red area. There are also other synonyms for this entity, but all of the authors found a weakness of the posterior inguinal wall, or some found also a widening of the internal inguinal ring. So the aim of this study was to get health-related quality of life data in the long term. We compared this data between sports hernia patients and groin hernia patients, and we compared this data with population norm. We included all patients between 2000 and 2005. These were 559 patients, and we sent out this questionnaire to all alive patients. There were statistical difference in the age between the two groups. We had a response rate up to 70%. There was no difference in the long term regarding postoperative pain. It resulted in 0 points median visual analog scale. However, there was a significant difference in 7 subscales of the SF36 between the sports hernia group and the groin hernia group, mostly due to the fact that sports hernia patients are sports active and the more healthier patients, but especially because of the difference in the mean age. But looking on the groin hernia patients compared to the population norm, we didn't find any significant difference, and we didn't find any significant difference in the sex and matched population norm in the summary scores. And the same is if you look on the sports hernia patients, also compared to a sex and age-matched population norm, we didn't find a significant difference. Only in the vitality score and the mental health score, we found better results compared to the norm population, and we found better results in the mental component summary score compared to the norm population. So I conclude, Tapp repair for groin hernia and sports hernia results in good long-term health-related quality of life, and Tapp results are comparable to population norm data or even better in the sports hernia group. And these results may influence the further indication, and especially in professional athletes, it might expand the indication for the Tapp repair. Thanks very much.
Paper is open for discussion. I'll start it off by asking you about the instrument you chose. You chose the SF36, and we've seen some other people present hernia-specific outcome scores, saying that the SF36 isn't really written for groin pain and hernia outcomes. Why did you select the instrument you did?
Yeah, the main thing is that looking in the literature, most use the SF36, and we wanted to compare this data with our data, so that's the point why we used it. Of course, it would have been better to additionally use a specific questionnaire.
Okay. All right, at the side microphone.
Thank you for this very interesting presentation. My name is Amir Sold from Israel. About the sports hernia patients, I think since you're not repairing any anatomical defect, until you can draw the conclusion that you have concluded, it would be, I think, better if you compare your operated patients to non-operative treatments. So, for instance, if you put these patients to bed rest and physiotherapy for 3 weeks, as you would for surgical patients, I'm not sure you would get much different results. So until then, your conclusions have nothing to do with your data.
Yeah, looking on the literature, I think that the operative treatment, it doesn't matter what kind of operation, if open or laparoscopically, leads to better results, especially in the professionals who have to return very fast to the daily activities because they earn the money with the sports activity. It's better to do the operation than the conservative treatment where you lose 3 to 6 months of time where they can't actively do their sports.
Can you support this statement with data?
Yes, there are a lot of data in the literature concerning this point. And especially in this institution, some of the sportsmen just came because they wanted to get operated and because we are known to do this, yeah. And there were like 20 professional soccer players who had to go back to the sports activity very fast.
Okay, we'll do Julianne and then we'll come over.
Thank you very much for this interesting paper. You're right, there is not much on long-term health-related quality of life in many of our surgical conditions. One of the things that strikes me is the intra-patient change as a metric of how good your intervention actually works, meaning the patient get better. You've compared the mean scores across the groups, and you show us that the mental health score and the vitality get better, which may be a placebo effect. We don't know for sure. But could you show if a patient had a score of 70 before surgery and their score was 90 after surgery for most of the patients, or is it just a random change? And because we test so many things, we get something that is significant.
Yeah, it's definitely a weakness of this study. We didn't ask for quality of life before or right after the operation. We just have this long data. But if you look on the literature, you see that if the pain gets better in the long term, maybe this might also be a reason why the quality of life gets better in the long term.
But your pain wasn't different.
Yeah, it was different. It was different in the comparing preoperative and postoperative. There was a difference, but we didn't see any significant difference in the long term.
A.J. Chopra from New York. I just wanted to ask you, how did you make the diagnosis of a sports hernia? Was any imaging done before to really come up with the diagnosis, or was it just a clinical diagnosis? As you mentioned, it was diagnosis by exclusion.
Most of these patients had an MRI to exclude it. In Austria, we are lucky. It gets paid by the insurance. So before rule out others, we had this MRI. Of course, all the patients were routinely clinically examined, and some had also an X-ray or CT scan, but this was varying.
And what are the findings on those to diagnose a sports hernia?
We found 4 real hernias, so we included these in this groin hernia group and not in a sports hernia group. And of course, there was like tendon disruption and adductor pain, and this was tried to be conservatively treated.
Yep, far side.
A sport hernia is an established entity today, and the findings by imaging and pathology are clear. Not exactly what you describe. I think that the next presenter would present the typical finding today of bulging of the posterior wall. It's a weakening of posterior wall with multiple tear on the conjoint tendon, as you say, and others. So there is a real pathology that you can demonstrate, and by dynamic ultrasound or CT with strength and without strength, you see the bulging back and forth. And this is very typical, and the syndrome are typical. So it's a really established entity today. My question for you, it's what is the results on the sport hernia? Because it's, when you say recurrence, it's not recurrent hernia. Those athletes suffered from pain on extreme exercise of rotation, sprints, and etc. So failure or recurrence, if the pain recurrent persists, what is your result?
It is described that up to 5% get a recurrence on local pain. In our group, no one got pain again, and we didn't see a real hernia after this period. There are interesting data from a big case series from Greece, where they operated on both sides, even if there was only one side with the chronic pain, and just to prevent the pain on the other side. But we just operated the side where the pain was, and we didn't see any recurrence in pain and no recurrence in a real hernia.
Thank you.
Your microphone.
Emmanuel, thank you for your presentation. Emmanuel Agaba from New York. My question is, most people, after one of the complications of hernia repair is chronic groin pain. Now, in this sport hernia patient, where from your conclusion, you suggested that Tapp repair is probably the preferred method of repair. Now, what happens when this patient comes back with pain? Are you going to go in and remove the mesh, or what's your advice?
No, actually, I think you should try to go on with conservative treatment, put in local anesthetics and physiotherapy. I don't think it is reasonable to put out the mesh, because then you produce a big defect and you're not sure if the pain resolves. And wait.
But from your definition, sport hernia is a diagnosis of exclusion.
Yeah.
The patient didn't have any hernia to begin with. You created a hernia, or you created a defect in the course of your repair.
Sorry, I didn't understand. We put on the mesh in the Tapp method, so we just reinforce the posterior wall, and of course it might matter if you use absorbable fixation, if you use fixation or no fixation, but this was not the aim of the study to look on this. And just the results say that we don't have pain in the long term.
Okay, thank you.
Thank you.
Okay.